Good evening, everybody. Am I audible to all? Okay, so we begin with our today's class on CAIRS, Corneal Allogenic Intrastromal ring segments. I, Dr. Krish Amin, will be presenting it under Dr. Niveditha Narayanan. I just wanted to let you guys go through this little tidbit about how keratoconus management evolved over time. It was the early 1750s when keratoconus was first noticed. 1850s the term was coined, and in 1880s we started using contact lenses for keratoconus for the first time. 1900s we did PK first time ever. 30 years later we used it as a treatment for keratoconus. About the time when 1990s came, we thought for a short term that maybe refractive surgery could also be used as treatment. In 2000, we started using C3R for it. In 2004, the intracorneal ring segments were introduced, and CAIRS was first done in 2018. So today's objective, the purpose of today's presentation is to let you all know what is CAIRS, what is the purpose, the patient profile, how we evaluate, what is the procedure, what is the post-operative care, the limitations, follow-up and the results. Let us go through what is CAIRS. So it is the placement of allogenic tissue-based ring segments inside the corneal stroma to correct the keratoconus using fresh, preserved or processed tissue. What is customized CAIRS? Customized CAIRS is a term we use, which is a new technique where we are tapering the segments and which is tailored to each patient's topography using varying volume, arc length, and the gradient for the target of flattening. What is the object of customization? It will give us a more symmetrical corneal curvature. And what is the advantage? It is that it has a high customization compared to synthetic ICRS and it has infinite options for the customization. So what are the principles? They are similar to ICRS. Arc shortening effect, spacer agents, it widens the collagen fibers at the insertion site, it alters the corneal curvature and corneal regularization. What is the law? The baracular thickness law comes into effect, which is that insertion of tissue in periphery creates a flattening effect central to it. So why did we decide to shift from index to CAIRS? With index, we had few of the complications like extrusion, migration of the rings, the corneal melting, the acute stromal necrosis, and corneal neovascularization, which we wanted to move on from and find a better option. So we moved on to CAIRS. So what are the benefits of CAIRS over index? First of all, we use allogenic tissue. It can be combined with CXL. There are less chances of melting. It is more compatible. It has less chances of vascularization. What are the indications? Indications for now, most of the surgeons practicing it worldwide are using it for keratoconus. The newly evolving one is for post-LASIK ectasia as well. What are the criteria that need to be considered? We have inclusion and exclusion criteria like for any other procedure. The inclusion criteria we have taken here is progressive and asymmetric keratoconus. There should be decentered, peripheral or pericentral cone. The cornea should be clear. Thinness pachy of more than 350 microns is considered, and if the patient is intolerant to contact lens. What are the exclusion criteria? In patients with active allergy, autoimmune or immunodeficiency syndromes who are having history of viral keratitis, mothers who are pregnant or lactating, central paracentral scarring in cornea, thinness pachy less than 350, and ocular comorbidities or history of ocular surgery. What were the preoperative and the postoperative assessments for these patients? Preoperatively, we did a thorough slit lamp examination. The visual acuity, both uncorrected and best corrected, was noted. A fundus examination, a contact lens trial, imaging by pentacam and anterior segment OCT was done. Postoperatively, the patients were evaluated on days 1, 7, 30, at 6 months and at 1 year. So what is this customization that we are talking about? Let's try to understand it. First, there are keratometric maps. So we are assessing the keratometric map of each patient. This will help us to decide where to insert this segment. The gradation of the keratometric values in the ectatic zone on the axial curvature map was evaluated. So what was the criteria? The asymmetry in the keratometric values across the meridia within the ectatic zone was identified. In such cases, a topographical plan was created for each patient, which would specify the total arc length, and the location of the tapered zone. You must be confused by this, so let's go through the pictures and try to understand it better. So over here you can see the axial sagittal map, which is a large curvature map over this. On the left side you can see. So in this, if we divide it, zone of division in 3 zones, zone A, B and C. The area of the cone was divided into these 3 imaginary zones. Over here the keratometric values are mentioned and this is the area of the cone. Okay. So the maximum values over here are noticed to be here in this area. Okay, so in this area, we divide it into 3 zones. The zone A, which demarcates the start of the cone, corresponding to the area of the initial steepening. Zone B, which represents the area of maximum keratometric values, where cone is the steepest. And zone C marks the end of the decreasing gradient of the cone, where cornea starts to flatten. So in this area, if we divide it into a zone A, B, and C, then there will be 3 areas which we will get from this. There will be an area which will be between A and B. There will be an area between B and C and the overall periphery. Okay. So the area between A and B was designed with a uniform thickness to correct the steepest part of the cone. Considering that zone B will represent the steepest part of the cone. So between A and B, if we are considering, then in this zone, the thickness of the segment will remain the same. It will be going towards the peripheral part of the cone. As much as the cornea starts to flatten, we can start tapering the segment in this area.
Which is your A zone?
Yeah. More images.
You should have marked it.
Yeah. I put another picture with the segments.
Okay, so now we place the ring at 6 mm. So this is 2, 4, 6. So this is our placement of the CAIRS in this particular case because the cone is decentered inferiorly. So in this meridian, across each zone in a meridian, you see the difference. Suppose let us assume this is 10. Meridional difference of astigmatism here. It is 10 here, it is 12 here, it is 12 here. I'm just telling you a random number. 12 I didn't calculate in this graph. 12 here, 10 here. Here it is reducing. So maybe it is 6, it is 3, it is 3. So we know in this map from here till here there is a high astigmatism. But between this spot and this spot it is somewhere around 10. So this is the area of maximum astigmatism and this area only will be corrected by placement of CAIRS 6 mm. So when you want to fix a CAIRS at 6 mm, you need to create a central pocket to straddle this. So we normally do from here 5 to 7 or something like that. So what is your zone A, B and C here?
That is just a rough telling
So
of
what this is your area. In this also, when you want to customize, you segregate this whole area into different zones. Suppose from here to here it is 10 and above. So that will become start is A, end is B. So from here to here it is less, say 6. So that is these two edges will be less. So you taper in the edges and the area which is here will get the maximum. Forget about ABC. You start from here, this is A, B, C, D. So A to B is less, B to D is maximum, and C to D is less. So you taper this area and you taper this area. These areas get full correction. Understood? So it is only in the 6 mm ring.
The ABC zones are just a rough representation. It will just make you understand that the greater volume of tissue was added to the meridia which required the most flattening. And this is the meridia which will show, as ma'am explained, the difference of the corresponding meridia was considered and the thickest was placed where it was needed the most.
I will just show here. Yeah, I'll just show here. If you look at this map, this is the 6 mm. But when you look at this meridia, it is 48 and 39. So the difference is almost 10. So that's what I look at. The difference in that meridia between the opposite sides, 48.4 and 39. So it's close to almost 10. So though this area looks steeper, but at 6 mm, I look at the difference. So it's definitely 10. Understood?
Well, in cats also, they have always been put at 6 mm, right?
Yes. Intact also. Closer you go, the more is the changes. We don't want to compromise the visual axis. So it's always better to stay safe for which is 6 mm. But actually, CAIRS, they claim you can come up to four zones. Susan has done. I'm little not yet confident.
Like this, roughly if you can see the appearance of the cone and the placement of the segment. Let's move on to the key parameters. Yes.
This tell us diametrically opposite is how much this is?
Here you
3 point
see
something.
this one, you see this, you see this,
And this
you see
one,
here,
this would
you
be
see
the
here. And then you plan
from
accordingly.
here to here.
Either you want to keep that long or you want to keep a short one here. So the CAIRS placed.
Yes, ma'am. The left one is
CAIRS.
yes, ma'am.
This is
No, ma'am.
CAIRS.
This is the pre-map, and I have just shown a rough to tell you where the cone is and where the placement looks like. We'll go in detail further ahead. So let us discuss some of the parameters that are being considered by the surgeons all over the world for CAIRS. Different nomograms are in use right now. So we have different parameters which we can use, which like keratometry, K-max, the corneal thickness pachymetry, the corneal shape, and the refraction. So for K-max, if it is between 47 to 50 diopters, thinner segments of 150 to 200 micron thickness are being used. For moderate, 50 to 55 diopters, thicker segments of 250 to 300 microns are being used. Corneal pachymetry, 350 is the standard segment placement in this column. Corneal shape, in this we have a symmetrical bowing. So if we have a symmetrical cone, equal length segments are being placed on both sides. If we have an asymmetrical cone, a longer segment is being placed on the flatter media to balance the reflective error. For refraction, we are considering the myopia and the astigmatism magnitude guide segment thickness and placement. What are the practical guidelines? The segment positioning is usually 50 to 70% depth of the corneal thickness at the implantation site. This also may vary between surgeon and surgeon because most of the surgeons prefer a 20 to 40% depth. What is the avoidance zone? Ensure segments do not overlap the thinnest corneal area. What is the customized approach? We have a tailored segment thickness and arc length, which is based on the individual topography. Now, this is the Istanbul nomogram, which was earlier being used for ICRS, which has been modified little bit by the makers itself to be now used for CAIRS. What are the key features? We have a segment selection, which is based on keratometry K-max values. We have a placement of depth and arc length. So segment selection based on this is if less than 53 diopters, the single segment is being used, typically 150 degrees or smaller, which is placed in the steepest meridian. If we have 53 to 55 diopters, then two segments with a total arc length of 320 degrees to 340 degrees are being used. And if more than 55 diopters, then two segments with a larger arc length are being used. The placement depth, like I said before, 50 to 70% of this. The arc length is the symmetrical keratoconus will have equal arc length and asymmetrical cone will have a longer arc for the steeper meridian. So now,
So what I don't understand is
yes, ma'am.
What is in degrees? Length 320 to 340 degrees.
Ma'am, that is the arc length of the CAIRS segment, ma'am. Before putting,
But saying in degrees.
yes, ma'am. We'll be using the CAIRS customizer. On this, you can mention how the degrees are being placed. Most of the surgeons prefer it to be a 160 degree, 150 to 160 degree. It will come ahead, ma'am, in another diagram also. So what is the nomogram, and from where now we have different nomograms and different calculators being used over the world. The Istanbul nomogram is the one which is being used currently by the Istanbul University, and we have another nomogram on the left that you can see is being used in the American areas by few of the surgeons, which takes into account a decentered cone and a centered cone. correlating to the segment size and the depth of the placement. In the decentered cone, we are using one segment, like we understood. For that, we have a K max or the K center diopteric. In that, you can see if it is more than 6 diopters, we are using a segment size of 750 microns and at a depth of 250. Most of this you will see on the depth size is not more than 300 microns.
So segment size is 750 micron.
I think they are considering the overall width.
Micron.
Yes, no, width they are considering. They have written as size, but they are considering it as width in this nomogram.
It's not 50 microns width.
The breadth.
The breadth.
Cornea is the turn, so you will have the 100 microns.
Then for centered cones, we will be using 2 segments. So similarly, they have described it as at what depth they will be putting it. Most of them don't put it more than 300 microns depth. And the Istanbul protocol, like we have discussed, approximately the size of the ring will be 160 dBr. There will be it will be 1 mm wide. They have also given us channel diameters and depth. So these are the channel diameters and depth which are created by the femto laser. The inner diameter will be 4 mm, outer will be 7.5. The depth is 200 to 250 for this nomogram. The incision cut energy they are using is 1.3 microjoules and the ring energy that they are using is the same. The incision cut length also is different, localization is also different. So for all of them, the principle of using a single segment for an asymmetric cone stays the same and double segment for a symmetric cone. For all of them, there can be a difference in the channel diameters and depth and also change in the arc size or arc degrees. Now, this is a CAIRS calculator. It was developed by Dr. Brendan Cronin and Dr. David Gunn. In this, if you can see, you can put the patient information. You can even upload the topography of the patient and it will show you where to place the segment as shown. So this is the same map. Over here, if you can see, on the right side, you can see that the calculator map is being shown and the segment is to be placed is shown in the lower diagram.
What map you upload? Sagittal map.
Yes, ma'am. Topography. We consider axial sagittal curvature maps. So this is how we decide to go ahead with the customizations and the size and the depth and everything.
Now let's.
Yes.
When I started, this online calculation was not available. I had done by oral advice from Dr. Susan. So when this came up, I just wanted to cross-check whether, because none of them actually tell what you actually see to calculate. They just say, upload the parameters, we give you the map. So I just wanted to cross-check whether what I am doing correlates with them or not. So that's how I tried this. I have made a better, this is my diagram using the PPT, this looks a little bad. I had corrected it to this, something similar to this. I think why she has not checked with me to change this. So when I did, I felt the clock hours, what we are calculating is sort of similar to that. So that's how I know that axial curvature map at 6 mm and the meridional difference is a reasonable start. So I would stress again, it is a reasonable start only, because in the subsequent slides, we will find out how these things change. So now let us move forward towards the procedure itself. Dr. Susan Jacob has already patented few of the instruments. As you can see on A, there is a double bladed trephine. Then we have a Jacob-CAIRS customizer. And the other instrument list that she gives for the procedure is clock gauge marker, a single blade radial marker, a curved Y rod, and a curved reversal. Just pause a little bit. Here again, I will tell you, this is a double blade. You can have 6, 7.5. Here it is 7.5, 8.5. So 1.5 mm width we can have cuts here. And this comes for a couple of times and then we have to buy a new one. Currently I'm using disposable ones, our own normal ones. You can do double punch with a little care, you are able to get a reasonable cut. Which one should be 0.5? 0.5. I take a little one. And in her thing? She also has variable. This is
You can adjust.
no, this is fixed. This is 1.
8.75.
8.75.
So 1 millimeter.
1 millimeter. 1.5 is the
This is the breadth of the.
correct. So when you cut, this will be after debriding the epithelium, you make the punch. And after debriding the epithelium, removing the descendants, you get the punch. So this will be the Bowman side up when you punch. So this will be sitting on this. Okay, Bowman side up. That area she tells us to stain it with the marker pen so that we know clearly what is the orientation of the graft. And this is a very beautiful customizer. This matches the actual size of the eye. So you have these each gradations 2 mm, 4 mm, 6 mm. If you leave it confusing, you have to clearly look into that 6 mm mark and the clock hours. So once you finalize that, you can beautifully keep in that particular area and mark. Suppose I want this clock hour to this full thickness. From here to here, I want tapering. I can mark this, and this. So and then I can keep it on a flat surface and cut accordingly. So this one is a very, very useful tool when you want to customize.
We'll move ahead with the CAIRS preparation procedure. So the donor cornea selection is a non-edematous corneal rim. It is negative serology for anti-HIV1, HIV2, Hep B, C, and venereal diseases. The corneal rim processing is then mounted on a. This is different for different surgeons. This is what Dr. Susan Jacob has described, which I have put over here. She has mounted it on a barren artificial anterior chamber. Epithelium was removed, and corneal center was marked using a Visumax 500 kHz femtosecond laser platform. Then we have a Desmith's membrane stripping. The cornea was dismounted, placed upside down on a Lieberman Teflon block. Central mark was done aligned with the block center. And then we did the ring segment creation, for which we use the double bladed trephine. In over here, she has written the inner diameter as 6.7 and outer as 7.5, which can also be customized. Now, 2 concentric cuts were created on the corneal rim and a full thickness segment was obtained. Let us go through this in a more detailed way. How the segment was prepared. So for segment cutting, the circular stromal ring was punched and then inked with for the Bowman side identification. The segment was flattened with Bowman side on one side and the stroma on other, and customization was done by using it or marking it after putting it on the customizer and then cutting it with a 15-degree side fold blade. The CAIRS, which was flattened and then it was placed, as you can see in the images, so she has put it on the customizer, and once it is prepared, we move on to the patient and we go for the channel making. The intrastromal channel is created using a femto laser. The corneal marking is done before that so that we are aware of the marking once it can change after docking. The cornea is marked at 0 degrees, 180 degrees in sitting position using a slit lamp beam, or I think it is different from various.
Most important, because all that we do works well only when the positioning is perfect. So you need to mark the patient in the slit lamp or whatever, just like how you do for toric lens. So that is the limbal, you mark the 3 and 9 o'clock. And then again you have to make sure that you are marking the visual center so that that spacing will be perfect. And then when you align that with your femto channel creation, everything becomes good. So this is something very important.
For the channel creation, the measurements also vary for surgeon to surgeon. The inner diameter is 6 mm, outer is 8 mm, or some surgeons prefer inner diameter of 4 mm, tunnel width of 1.5 mm. So 50% of the minimum pachymetric in the 7 mm or 6 mm optical zone, maximum up to 280 microns of depth. The laser energy, and after that we can open the incisions using symmetrical glide or surgeon's preference. How do we position the CAIRS segment inside? Now, in this, she is showing that we have coaxially marked first the center. For few surgeons have already marked it before in a position, which already ma'am explained. After that, what we do is we go with a gauge marker and a Jacob single blade radial marker is used. It will mark the clock hours as per the individual patient's topographic plan. Now, as you can see in the first and the second, she is marking. After that, the C and D is the radial gauge marker. In the D, she is opening it up. For D, right and left Jacob curved Y rods are being used, and Jacob curved reverse Sinskey hooks are used to insert the CAIRS into the already created channels. For cross-linking, we in our institute, ma'am has always done cross-linking together with CAIRS in all of our patients, as described by Dr. Susan. After segment insertion, only patients who are showing progression, which is a maximum keratometry value greater than 0.75 diopters in 6 months, underwent the accelerated corneal cross-linking. Now we'll come to the patient profile. The first patient that I'll be describing is a 20-year-old male. Both eyes he was having papillae, Lescher's ring, and both stria. The pentacam was suggestive for both eyes keratoconus. The pachymetry for the right eye was 363, for the left eye was 423. The right eye, CAIRS was planned with CXL and the topical. The workup preceding that was vision and refraction, the pentacam with a large color map, the specular microscopy of the patient, and MS39. Over here, if you see lower below, the vision, kindly note that the sphere was minus 12 and half. The cylinder was minus 1 at 105 with 6.9 of best corrected visual acuity. Let us see how it changes post the operation. Pre-operatively, as you can see over here, the curvature map shows that the patient's K1 was 55.4 diopters, K2 was 57.8, the thinnest patty was 363 microns, and post 4 months when you come to the same patient, the K1 has become 49.7 diopters, K2 has become 53.1 diopters, and this is the third and the final map which you can see is the difference map between both, which shows a flattening in the area where the CAIRS was placed. And below that, if you can see over here, the three places are describing the evolvement of the patient's vision. So immediately post-op, the patient was having a sphere of minus 11, no astigmatism. Post 4 months, that same patient had a vision of minus 3.5 sphere, minus 4 cylinder at 100 degrees, and 6 by 9 vision. What is the post-operative treatment and evaluation that we are doing for all the patients? For this patient, we did OT CAIRS with CXL, HPMC, UV radiation was given for 10 minutes, it was done under TA. Post-operatively, we have given Lotepret eye drops 2 times for the 4 days till the BCL was there. Post the BCL removal, we have gone in a tapering area of 4, 3, 2, 1 and stopped it after 4 weeks. The refrigerator lubricants were given for 6 times. Vigamox was given for 1 week, 4 times. While the BCL was in place, we used it for 6 times. Ciplox ointment was given at bedtime for 1 week. When was the BCL removed? After 4 days. When was the suture removal considered? After 2 to 3 weeks. When was the revision and refraction repeated? At 2 weeks. And post-op pentacam was done at 3 months. Anything you want to?
So that was the first case.
So, ma'am, at what
This
period
one,
post surgery do you think the vision stabilizes, ma'am?
it keeps changing 6 months at least. There is a change. So, but unpredictability is as we see more and more, we will see how each case is different. In the first case, just go back to the previous slide. This amount of drop in spherical I did not expect. Because to get this dropped to 3, you need a symmetric rings. That's what our intact lessons teaches. You have to have a symmetric rings to get the sufficient flattening of the cornea. So when I started doing CAIRS, I was only looking at getting down the cylinder or regularizing the bone. So in this case, we have to opt for GALC because the patient was not comfortable with glasses and other is plano 6.6 and he is not willing for contact lenses. So that's why I decided on CAIRS. But if you look at the result, he unaided only he was improved so much that he was so happy. But this sort of a change, I don't know how it happened. And it keeps changing. At 1 year he was this much. And after that there is little change, but not much. But there is some amount of change still going on. So 6 months definitely there is a drastic change. Beyond that it is less, but it is still too early to say when it stops.
Moving on to the second patient. She was a 24-year-old female who was a known case of right eye keratoconus, left eye FFTC. She was having history of eye allergy and eye rubbing, and she was also having hypothyroidism. On examination, we noticed that right eye there was pressure ring, prominent corneal nerve, scissoring reflex was positive. The left eye appeared to be normal. The right eye was planned for CAIRS with CXL under TA. The workup was done, same as which was done for the previous patient. Over here, you can note the vision. Preoperatively, the patient was having a minus 3.5 sphere, minus 4.5 cylinder at 40-degree axis, and a best corrected visual acuity of 6/9. Now let us go in a more detailed manner than the first patient for this. So as you can see in this patient, the right eye axial sagittal curvature map will show us that the K1 for this patient was 47.1 diopters, K2 was 51. The thinnest pachymetry was 424 and the Q value was minus 1.04. When we applied CARES for this patient, the post-operative, as you can see, the sphere had vanished. The cylinder had come to minus 1 at 100 degree. Pre-operatively, the cylinder was minus 4.5. This is the ASOCT examination of the same patient showing us the CARES placement. This is the post-operative of the same patient. The comparison will show us flattening in the area of the.
So now when you look at this post-op axial curvature, it looks very distorted. So if you see a patient untouched with this, you will expect the patient to have a very poor vision. But this patient post-CARES, the vision improvement is more. So we are not able to correlate what we see in this test and actually what the patient is actually seeing. So those are the things that we need to learn more.
And as you can see, the K1, K2 values have also changed. The K1 preoperatively was 47.1, post-operatively it has become 38. K2 was 51, post-operatively it has become 45.8. The same patient developed the right eye conjunctivitis 6 months post-operatively. She was started on topical Cretford eye drops 10 times with 1 week of tapering as well as oral steroids with clearance. It resolved 2 weeks later and the same patient had still stable CARES. For the same patient, 1 year post-op evaluation, you can see that she was maintaining that vision and it was still 0 for the sphere and minus 1 cylinder at 90 degrees with 6/9 best corrected. This is our 1 year post-operative evaluation. Let's move on to the third patient. She was a 20 years old female who was known case of both eye keratoconus, right eye worse than the left eye. There was history of itching and eye rubbing which was positive. Both eyes were having signs. The right eye was planned for CARES with CXL. For the same patient, please note, the sphere was minus 0.75, cylinder was minus 2 at 20 degrees. The best corrected vision for this patient was 6/18. So, let's look at the anterior axial curvature map. For this patient, the K1 was 57.5 diopters, K2 was 66.4, the Q value was minus 1.71, and the thinnest pachy was 381 microns. Once the CARES was done, in this you can see a pre-operative mapping for the steepest area. Just when we were customizing, you can look at this and roughly imagine where the CARES was placed. The same patient had developed edema surrounding the tissue 3 months post-operatively. As you can see in the image on the left side, there is a mild swelling, minimal edematous graft, and the suture also seems to be little different than it was previously. So we went for OD CARES removal with the suture removal, which was done in OT. As you can see in the ASOCT as well, the immediate post-op doesn't show as much swelling as the post-op shows when it was done during the edematous corneal
And
time.
this is the immediate position posterior bowing. It is described already. So over a period of time, as this settles down, this sort of a bend smoothens out and it becomes more compact. This elevation on the surface is noted only in this patient just because suture-related irritation had opened up the incision. She must have rubbed her eye or something, and then that had caused this distortion. She just insisted on removing it. I gave her the option of just removing the suture, tightening it a little bit, and then things would have settled down. but she was not keen, so we removed it. So this opening, we have the facility to do it with the our femtoplanning. We have one incision only. So the other one, nowadays I don't do. Initially I used to do, where the hair is supposed to end 2 clock hours away, 2 or 3 clock hours away. I used to do, so that will help me in pulling it. Yeah. Suture I do only here one side where it is. So this is post removal. It has stabilized and she has not lost her vision. Slightly, even the cylinder is little less. She is happy with this. So the channel must have caused some flattening probably, but this is a complication.
Those three different patients have been described. Relating to that, now let us look at results of few other patients. Over here, I described to you 5 patients with completely different results. Let's look at the first patient. She was a 23-year-old female who had come and who underwent unilateral CAIRS, and final follow-up was for 8 months. So if you consider her refractive error pre-operatively, it was a -3 of sphere, -4.5 of enzymatic cylinder, which came down to -1. The K1 came from 47, it became 40. The K2 51 to 46. And as you can see, the Q value has reduced from -0.96 to -0.05. All of these patients show stabilization via the Q values. However, the difference for refractive error results is quite unpredictable for every patient. For the second patient, as you can see, our refractive error did not change much. However, the K1 from 55 came to 36, K2 from 58 to 56, and the Q value from -1.42 to -1.22. Similarly, if you go to the other patients, for the third patient, he had a high refractive error of -12, -5.75 at 180. It came down to -5.5 and -4 cylinder at 60 degrees. The similar results in K1, K2, Kmax, and the Q value. For patient 4 and 5, if you can see, for the fourth patient, the refractive error relatively remained stable. However, the best corrected visual acuity for this patient improved. And for the fifth patient, there was a high change for the refractive error. -12 decreased to -3.5 of sphere, and -1 came to a -4 of astigmatism. Now, as you can see, for this fifth patient, the Q value had stabilized -1.51 to -0.87.
So to sum up, out of my initial 10 cases, there was nobody who lost vision. So they either maintained their BCVA or they improved. And in refractive error, most of them benefited, either in a drastic drop in the spherical component or cylindrical component, except for 3, I think she has not put that slide, 3 patients in whom there was a increase in cylinder, but there was maintained or either improved visual acuity. Kmax, always all of them had a reduction. The reduction in Kmax was mainly because of more flattening of K1 than flattening of K2. Even in the patients who had an increase of corneal astigmatism, it's mainly because of the drastic reduction in the K1 rather than an increase in K2. All the patients had a less hyperprolate, Q value reduced, less hyperprolate cornea except for one patient, I think, and that patient also benefited from the procedure. So far, it's been a promising.
Let's come to the complications of CAIRS. Even though less studied, there have been few complications that have been identified. The intraoperative complications can be related to the procedure itself. Using the femto can create a channel dissection issue also. Incomplete or irregular channels can happen. The segment misplacement can also happen. Early postoperative complications can be inflammation and discomfort to the patient. Sterile inflammatory keratitis, graft versus reaction, rejection, anything can happen, but it can be managed with topical steroids. What are the late postoperative complications? Over here I have mentioned about 5, but many more can be added once we get a overall view and a long-term follow-up. First is extrusion or migration. Same as ICRS, this is also possible with CAIRS. It is rare, but it is possible if they are not well integrated. Second is epithelial ingrowth. Over the segment channels, it can cause irregular astigmatism. Third is infection. Like with any other procedure, infection is also a complication of CAIRS. Fourth is corneal nevascularization, rarer than ICRS but can occur. Over and under correction. So the patient can have a suboptimal visual outcome due to the inaccurate segment selection or positioning. Moving on to few of the other allogenic treatments that are still under research or on the way, we have a Bowman layer inlay onlay transplantation. We have a CTAC, which is corneal tissue adhesion keratoplasty, and the last one is the corneal stromal regeneration. Corneal stromal regeneration procedures are still underway. They are still half of them are still in the stage of animal study research. We have injectable intrastromal things which can act and form itself like a cornea and give improved stability. So finally, summing up, what are the challenges and what are the opportunities of CARES? CARES may have a poor predictability, but it is just because we are still studying what it can do and what it cannot do. There are few guidelines that we know, but we still need a uniformity in guidelines all over the world. The complications need to be studied. Repeat procedures, once CARES is done, what are the procedures we can or cannot consider for what way it will behave if the patient undergoes another procedure. We do not have more data about that, and as well as what is the long term outcome also we don't know. The opportunities are that it is a newer approach which is very promising. There can be a need for PK in patients which can be stopped by giving them a trial of cares before, and it also has proven that it can help with stabilization and corneal regularization. These are all my references that I've used, mainly considering regarding Dr. Susan Jacobs' paper as well as the other normograms, the Dr. Aylin Kilik for Istanbul, and we have few other Dr. Jacob, Dr. Fatima Faiz, and everybody who has worked for this. I thank ma'am for guiding me through this, and thank you everybody for patiently listening.
Ma'am, would you like to add, ma'am? If ma'am is there.
Yeah, ma'am, it was a nice talk, Krishna. We must, as you rightly pointed out, there are just so many questions that this throws up, many of which we don't have an answer for. But basically, at least three things are happening when you introduce a tissue into the cornea. One of the most obvious are the shape changes that it induces. And depending on where you put it, the length of the arc and things like you showed, it alters the amount of flattening that it induces. The second, which we have really no clue of with the instruments and with what gadgets we have, is the redistribution of stresses that are happening within the cornea. Basically, keratoconus is a disease of biomechanics. And here we are introducing something into a weak cornea, whose initial biomechanics is not even taken into account. You're designing the entire surgical procedure. You're only taking shape changes into account. So the redistribution of stresses is a very important factor, I feel, which is difficult to evaluate and difficult to calibrate or titrate. The third are the very dynamic changes in the epithelium, which again, to a large extent, actually explains some of the changes that we see, but also might explain why there is variation. So we need to study a lot of the other factors, and I understand the apprehension of moving too close to the center or moving away, because when you say 6 millimeter diameter, it's really 3 millimeters away from the center of the body, which can fall into the pupillary axis as well. So I can quite understand the apprehension of going too close. And then, like you showed in one of the maps, we're actually now introducing a multifocal cornea, where it was steep, but it was more uniform. Here it becomes a multifocal central cornea. So what it does to the aberrations, to the coma, and to the quality of vision, we need to study. Not saying that that's not the answer to it, but we need to look at what I'm trying to emphasize is that there are many factors we need to look at even when we evaluate these patients. So I was suggesting to Niveditha that we also look, in fact, in all these patients, the follow-up is extremely important, but keeping track of the changes in the ASOCT. If you noticed in the ASOCT, it's actually producing a big dent in the posterior cornea. It was so much, it was placed in the anterior cornea. There was a big bulge towards the posterior cornea. And how it compacts over time, what it changes, in what dimensions it actually stabilizes, and keeping 6 millimeter, especially with a paracentral cone, you may actually be going through the cone. Whereas I would expect that your intention would be to bolster the base of the cone. In a paracentral cornea, 6 millimeter diameter, that is 3 millimeter away from the center of the cornea, may actually be the cone itself. So again, we need to study. We need to learn. This is a big learning phase for us. And I think only close follow-up and studying these patients in all its aspects is important. Sorry, I couldn't make up what you say. I could make up what you say.
Few words about the epithelium change.
Yeah. So, I don't know. Was that a question?
Yes, ma'am. I want your opinion on the maps that we did. The way how the epithelium.
Oh, okay. Yeah. That's something I'm still looking at because there is no. I mean, I was looking at all the follow-ups. So it's give me a little time and I'll put them together.
Sure.
I'm looking at all those maps in detail. But the other thing that I think you know already that we're working on is on a mathematical model. So what we can simulate without actually doing, without having to do it on a patient and not knowing what its effect could be. What we're trying to do is to create a mathematical model and simulate what the effect of the placement of this at various points, for various lengths, at various distances from the center, and including biomechanics into taking that into account. If we can come up with a protocol or an algorithm, which will give us some indication.
Ma'am, you just said we have to position at the base. Sometimes if it is a paracentral cone, we can go through the cone.
Yeah.
If we have to make a mathematical calculation or algorithm, should we look at tangential maps rather than axial maps, which can locate us better at the base of the cone?
Absolutely. As we were discussing once, if you look at these asymmetric bow ties, it's very confusing because you don't know where the cone is. So identifying the location of the cone, and I think this is where something like a Galilei, which locates the cone directly for you, is useful. Unfortunately, our Galilei doesn't work. But maybe we could do this with the software that we have that locates the actual cone, and we can look at it in a few cases.
Yeah, hi, very interesting class, Niveditha. Only 2 points. I've seen some of these patients post-ops, 1 or 2 in-house and 1 or 2 from outside. Quite often in that area, whether this is single incision or double incision, inevitably there is some amount of epithelial bunching up. You think that can be sorted out by making the segment a little shorter or some variation in the suture involved time? That is the first point. Second point is just a thought. Already I understand there are many variations. I don't have a hands-on view of the procedure. Then a thought also would be that if we can use decellularized cornea, then probably the collagen alone remaining may add value to the procedure because the predictability will be better, the tissue will be easier to handle. That is just a thought.
These are all preserved?
Yes. Decellularized cornea will be a little more like thicker, and it will be more like fabric, easier to handle. And the predictability and variability which involves hydration, dehydration of the cornea postoperative may be limited. There are so many other factors, but it was just a thought because this is a stiffer tissue, easy to handle, and less hydrative behavior in the postoperative period, as we have seen with decellularized graft with glycerol earlier.